That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in the woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm make it. Take 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina. Fifteen things you didn't know about sperm. Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes 2 months for sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in the woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg. Once the sperm penetrates the egg envelops it and they fuse together. Things you didn't know about sperm. Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes about 2 months for a sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in a woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg. Once the sperm penetrates the egg envelops it and they fuse together. Things you didn't know about sperm. Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes about 2 months for a sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in a woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg. Once the sperm penetrates the egg envelops it and they fuse together. Things you didn't know about sperm. Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. For a sperm to mature.
اتفضلي يا دكتور ازهار حضرتك
احاول من الكمبيوتر اسوي شيرنج.
اوكي يا
اول مره عندي الصوت بدا اسمع.
ايوه تمام كده اشتغل كده يا دكتوره الشير كده حضرتك بس يعني حضرتك وقتها كبري السلايد و it should be fine. يس
كبر السلايد. انا حقيقه لا ما احتاج اكتب بس مشي. ها هي. اوكي دكتور احمد.
كده تمام، تمام دكتورة أزهر. يس.
اوكي شكرا.
شكرا دكتورة، تسلمي. ثانك يو.
سراج جيب الايباد.
يا دكتور احمد شو طلع السبب؟ just for
مش عارف
information.
والله.
نعم دكتور.
مش عارف والله، بس يمكن أعتقد دكتورة أزهر لما استعملت اللابتوب بدل التابلت ممكن تكون كان في ريستريكشن عليها في التابلت من الادمن بتاع التابلت. كود بي.
انا يعني
طيب الحمد لله.
Yeah. احنا كده we started the live streaming on Facebook and on YouTube، وفي نفس الوقت we started recording، وإن شاء الله يعني 8 o'clock يعني sharp إن شاء الله we will start، يعني بعد 6 دقايق من دلوقتي we will start.
It takes about 2 months for sperm to mature. 90% of sperm are deformed. Perish in the Chinese sick environment. Millions more get trapped in the circle mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body. Only the fastest, bravest, most resilient sperm will make it.
فواز
اكيد
فواز كده
صاير
الصوت مش واضح.
صوتك واضح يا دكتور، بس صوت الميوزك تبع اللي حاطينها ابدا عم تقطع. صوت
طيب
الفيلم اللي
I will try
حاطينه
كده.
غير نوت كلير ومخربط يعني.
كده واضح.
دلوقتي واضح. كان اول كتير مشوش، فكانت زوجتي بتسالني لانه هي عم تتسمع هلا، فبتسالني انه واضح عندك، قلت لها انا ما واضح.
يعني هو اذا ما ترسل سكرين شوت.
90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. This swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in a woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg. Once the sperm penetrates the egg envelops it and they fuse together. "15 things you didn't know about sperm." Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes about 2 months for a sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. To swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in women's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. The fastest, most resilient sperm will make it. One sperm to fertilize an egg. Envelops it and fuse.
دكتور أحمد يمكن الصوت غير واضح.
Things you didn't know about sperm. Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes about 2 months for sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. To swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in women's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. The fastest, bravest, most resilient sperm make it. Only one sperm to fertilize an egg.
يهودا جيبي لي.
Once the sperm penetrates the egg envelops it and they fuse together.
كده الصوت مش واضح دكتور فواز، في مشكلة في الصوت.
سوري، لما انت بتظبط صوتك واضح. الفيلم
أوكي.
نفسه بعد فتره عم يتغير اللحن تبعه.
اوكي. طيب احنا يعني نبدأ within few minutes.
ما شاء
طيب
الله الاعداد عم تزيد بشكل متوالي، يعني دلوقتي 270 شخص حاضر.
يس ان شاء الله هظبط الساوند.
في 3 اسئله كلهم عم يقولوا sound is not clear. 3 اشخاص على ما يبدو انه نفس الشيء اللي نحن عم نسمعه، وهو الصوت اللي بنسميه يعني هيك في ضجه بالصوت، في رجه، بس هذا
طب انا
بعد ما الفيلم شويه تبع
هقفل السلايدز و I will restart it. ده يمكن علشان الشير بتاع
ما صوتك كثير واضح.
صوتي واضح يا دكتور ولا مش واضح؟
واضح واضح.
تمام، يبقى هي المشكلة بس في الساوند بتاع الكمبيوتر.
تسجيل.
ممكن يس يا اوكي.
"15 things you didn't know about sperm." Sperm is constantly being created. The average man produces at least 1,500 sperm cells per second. It takes about 2 months for a sperm to mature. 90% of sperm are deformed. Sperm travels in semen. The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in a woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg. Once the sperm penetrates the egg envelops it and they fuse together.
على ما يبدو بانتظار الناس.
15 things you didn't know
بس
about sperm.
دكتور شريف بيحاول يدخل 2 minutes we will start إن شاء الله. يعني within 2-3 minutes.
إن شاء الله يا دكتور. هي ما بالعكس، أنا اللي ملاحظ كمان في نسبة الحضور عم ترتفع أكثر، يعني كل ثانية عم يدخلوا ناس، فربما هذا كمان بيفيد. يعني في دلوقتي 324 شخص.
The amount of sperm in a typical ejaculation can be contained in half a teaspoon. That half teaspoon contains anywhere from 40 million to 300 million individual sperm. The swim upstream is a perilous one. Millions of sperm will fall out of the vagina or perish in the vagina's acidic environment. Millions more will get trapped in a woman's cervical mucus. As many as half will get lost by going up the fallopian tube that doesn't contain an egg. Sperm can live in a woman's body for up to a week. Only the fastest, bravest, most resilient sperm will make it. It takes only one sperm to fertilize an egg.
Hello everyone and welcome to Leptos Pharmaceuticals webinar. On behalf of the Vice President, Dr. Sharif Omar, on behalf of our guest speakers, Professor Dr. Azhar Musa, and also Dr. Fawaz, and on behalf of Leptos teams across Iraq, Saudi Arabia, and Qatar, I would like to welcome you all to today's webinar and wish you enjoyable and informative webinar. Today we have 3 eminent speakers: Dr. Fawaz Amin from Doha, Qatar, Dr. Sharif Omar from New York, United States, and Professor Dr. Azhar Musa from Middle Furat, Iraq. We will have 3 focused lectures and 4 credit hours for attendees. In addition to certificate of attendance from Leptos, a recorded webinar, and currently live streaming webinar on both Facebook and YouTube. We will start with the welcome notes of Dr. Sharif Omar. Then Dr. Fawaz will talk about the management of infertile couple, followed by presentation on of AfroFem rule in female sexual dysfunction, female infertility, and the couple therapy. And the last presentation by Professor Dr. Azhar about special infertility management. Then we will have a closed session for questions and answer, ended by closing remarks and certification. Just some key hints before we start. The mic is muted for all participants, and question and answer will be by the end of all lectures. And please use the question and answer window to post your question. And also we would advise to direct your question to which one of the speakers you would like to ask your question. If you get disconnected, please use the same link to rejoin, and the recording will be available for future review. And also, if you request any publication or references, will be shared with you upon request. So it's our pleasure to introduce Dr. Sharif Omar and welcome our Vice President of Leptis Pharmaceuticals. He is joining us from United States. And the first talk for Dr. Omar is a welcome notes. So welcome, Dr. Omar.
So good evening, everyone, and a very warm welcome to the Leptis Pharmaceuticals webinar. Before we start, I would just like to say that I hope everyone is safe and healthy during these pandemic times. We know how everything has been turned upside down with the COVID-19 pandemic, and we stand united with you in doing everything we can to continue to support you in your medical practice. To that end, we have adapted our communication medium to continue to bring you the continuing medical education that you rely on to continue your practice. And we're honored today to have two eminent speakers, Dr. Fawaz and Professor Azhar, who will be sharing with us their expertise and their insights. And I wanted to thank each of them personally for accepting our invitation to join our webinar and share with us their expertise. We look forward to a very informative and focused session from their presentations. I won't spend too much time with the introduction because we want to get started with our session. We hope that everyone finds it fruitful and informative and supports you in your practice. Bear in mind that Leptis stands united with you, and we will continue to work closely with all of our partners as we get through this phase. So thank you once again for joining our webinar, and I'll see you at the next presentation.
Dr. Fawaz Amin Saad, our first speaker is Dr. Fawaz is a senior consultant OB/GYN, Faculty of Medicine, Tishreen University. Also, he is the general manager of Al Hayat Medical Center in Doha, Qatar. And also, he is Arab board member of OB/GYN in Arab. Dr. Fawaz's topic is management of infertile couple. So welcome, Dr. Fawaz. Please share your slides.
Good evening. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ahmed. Thank you, Dr. Sharif. And good evening, everybody. Our topic today is the management of infertile couple. And our agenda is the definition of infertility, causes and risk factor for infertility in male and female, and also management of infertile couple. Infertility is a common condition with important psychologic, economic, demographic, and medical implications. It is a unique medical condition because it involves a couple rather than a single individual. Infertility is defined as inability of a couple to conceive after 12 months of regular intercourse without the use of contraceptive in women less than 35 years of age. After 6 months of regular intercourse if the woman is more than 35 years or older. Fecundability is the probability of achieving a pregnancy in one menstrual cycle. Usually, fecundability decreases with the number of cycles. As we can see here in this graph that fecundability means decrease from 25 to 30% in the first 3 cycles to about 10 to 15% after several months of trial. Infertility evaluation is indicated for couples who seek help because they have not been able to conceive. We initiate evaluation after 12 months of unprotected and frequent intercourse in women under the age of 35 years without risk factor of infertility. But if the woman is between 35 and 40 years, then initiation of evaluation will be after 6 months of unprotected intercourse. We initiate evaluation immediately upon presentation despite less than 6 months of relation in women over age of 40 years, in women with oligomenorrhea, amenorrhea, in women with a history of chemotherapy, radiation therapy, or advanced stage endometriosis, women with known or suspected uterine or tubal disease, women whose male partner has a history of groin or testicular surgery, adult mumps, impotence, or other sexual dysfunction, chemotherapy and or radiation, or a history of subfertility with another partner. Who should perform the infertility evaluation? Usually, any practitioner who has a special interest in infertility can start the evaluation. But obstetrician and gynecologists are mainly involved. Also, infertility specialists and reproductive endocrinologists. Female factor alone constitutes 37% of the infertility cases, male factors 8%, and male and female factor combined 35%. Unexplained infertility is found in 5%, and during evaluation, usually about 15% they get pregnant spontaneously. Male factor infertility usually is divided to 4 categories, endocrine and systemic disorders in 2 to 5%, primary testicular defect in spermatogenesis, about 65 to 80% of the case. Usually the majority of them are dys-spermatogenesis. Sperm transport disorders around 5%, and idiopathic male infertility in 10 to 20%. Female risk factors may include ovulation disorder in 31%, ovulation disorder in 31%, endometriosis in 18%, pelvic adhesions in 15%, tubal blockage 13%, other tubal abnormalities 14%, and hyperprolactinemia in 9%. With advancing female age, there is an increase in the percentage of women with age-related infertility. There is also increase in leiomyomas, tubal disease, and endometriosis. On the other hand, a reduction in coital frequency may occur. Risk factors of female infertility can be divided also to several categories: ovarian with ovulatory disorders, ovarian cyst, ovarian endometriosis or endometrioma; tubal can be pelvic inflammatory disease, endometriosis, adhesions from previous surgery, hydrosalpinx, and tuberculosis. Uterine factors may include submucous fibroids, Mullerian anomalies, intrauterine adhesions or synechia, polyps, and luteal phase defect. Cervical and vaginal causes include congenital malformation, trauma to the cervix from previous surgery, cervical stenosis, vaginal septum. Other factors may include ovarian age, male factor like varicocele, poor coital technique, and toxins and genetic causes. Ovulatory dysfunction, a lot of causes can lead to anovulation, but central causes are important due to intense exercise, eating disorders, stress, hyperprolactinemia, lactational amenorrhea, pituitary adenoma, Kallmann syndrome, tumors, Sheehan syndrome, empty cell syndrome. Other disorders include polycystic ovary, hyperthyroidism, hypothyroidism, hormone-producing tumors, chronic liver and renal diseases, Cushing disease, congenital adrenal hyperplasia, and many other cases. Medications also can cause ovulation dysfunction, like estrogen, progestin, contraceptives, or progestin alone, antidepressant, antipsychotic drugs, corticosteroids, and chemotherapeutic agents. World Health Organization classification of anovulation divided anovulation to 3 classes. Class 1, they call it hypogonadotrophic, hypogonadal anovulation. It's hypothalamic amenorrhea. Here, FSH is low with low estrogen or estradiol, while in normogonadotropic, normoestrogenic anovulation, FSH and estradiol are normal, as in polycystic ovary. And in class 3, hypergonadotropic, hypoestrogenic, here the FSH is high, while estradiol is low, as in premature ovarian failure. Also, the 4th category of anovulation is hyperprolactinemia, which inhibit gonadotropins and lead to low estrogen. Genetic causes of infertility are common, especially karyotype abnormalities like trisomies, mosaics, translocations. In female, the most common aneuploidies is 45X, while in male, 47XXY, Klinefelter syndrome. There are emotional and educational needs during infertility evaluation. We should always deal with disease, with infertility as disease of couple, not as individuals. And we have to deal with the feeling of guilt, with the feeling of frustration and anger with the patient as infertile patient. Usually, always they think it is a punishment or something for them for the sins which they did. That's why they are not getting babies. So this feeling of guilt or anger or frustration, we should deal with it and target it in a proper way. Otherwise, our management is incomplete. Also, the patient asks where to go for information. We have to help her and guide her. Also, she may ask, what are my options at these situations? And here also we should tell her what is her option according to her circumstances. There are support groups like Resolve. Resolve is a support group, can help the ladies to target their problem with the other ladies and find a solution for herself. When we evaluate, usually we target organ by organ, like ovary in a female, ovary, tube, corpus, etc. In male, we do semen analysis and we look to the ejaculate characteristics and anatomical anomalies in male. The most important factor in the evaluation of infertile couple is history. During history taking, there are general information can be taken from both couples. Both couples should be present during interview, and the age of both couples should be taken. Previous pregnancy by each partner is taken also, and the length of time without pregnancy. We took sexual history, frequency and timing of intercourse, the use of lubricants, impotence, and on anorgasmia and dyspareunia. We use also to take contraceptive history. It's important. Regarding male history, it's important to search for pelvic infections, radiation exposure, toxic exposure, including drugs, and history of mumps in the male, and testicular surgery or injury to the testicles. Also, excessive heat exposure or spermicidal exposure. For female history, we search for previous female pelvic surgery, pelvic inflammatory disease, appendicitis, use of intrauterine contraceptive device, ectopic pregnancy history, and history of endometriosis, irregular menses, amenorrhea. We should take detailed menstrual history from the patient. And also we look to the vasomotor symptoms as indication of premature ovarian failure. We look to the stress in the, with the patient, and we search for any weight change and any heavy exercise practiced in the past. Also, we look to the cervical and uterine surgery. On physical examination, we search in the male, we search for the size of testicles, testicular descent, presence or absence of varicocele, and outflow abnormalities like hypospadias. While in female, we search for thyroid problems, pelvic masses, uterosacral nodularities, abdominopelvic tenderness, uterine enlargement, uterine mobility, and cervical abnormalities. Always, we should take a break and reevaluate the situation of the patient. And for this reason, also, I will let you take a break and look to this. Life is hope is my drawing or painting during Corona time. And this is related to our topic. As we can see, this infertile couple looking to a baby in the sky, and they are attached with a heavy chain to the infertile land and infertile tree, and with hope, with patience, and with our support, they will break the chain and come to the fertile land. And this one was done last 2 or 3 months ago. Assessment of ovarian function usually start with documentation of ovulation, taking basal body temperature. Of course, we don't need to go through all this because basal body temperature is difficult, and usually some patients, they like to do it, but for me, I depend always on ultrasound for evaluation of ovulation. But all this can be also used for detection of ovulation. If premature ovarian failure is suspected, then we perform FSH. But TSH and prolactin and adrenal function also are indicated in some situation. The only convincing proof of ovulation is pregnancy. As we mentioned before, the 3 main types of ovarian dysfunction are central hypogonadotropic hypoestrogenic, or polycystic ovary normogonadotropic normoestrogenic, or premature ovarian failure hypergonadotrophic hypoestrogenic. Assessment of tubal patency. Usually we use simple way is hysterosalpingogram, but HICOSI can be used also for assessment of the tubes, but also laparoscopy is also used for infertility situation when we have suspicion of other pelvic problems like endometriosis or adhesions. Laparoscopy is invasive and require operation theater, can offer diagnosis and treatment in one setting, and not necessary in all patients. It can be used for lysis of adhesions, diagnosis and excision of endometriosis, myomectomy, and even tubal reconstructive surgery. Asherman syndrome is diagnosed by hysterosalpingogram or hysteroscopy. Usually is, we have history of dilatation and curettage or myomectomy or other intrauterine surgery. It's associated with hypomenorrhea or amenorrhea and recurrent miscarriage. Fibroids and uterine anomalies rarely associated with infertility, but the workup include ultrasound, hysteroscopy, and laparoscopy. The cervix is assessed by culture if we have cervical erosions or evidence of infection in the cervical assessment. We can do also post-coital testing. Usually in post-coital test, we look to the quality and quantity of the cervical mucus. And we found that the quantity is very subjective, but the quality should be stretchable more than 8 centimeters, and it should be clear and showing on microscopic examination the furning or branching module of the crystallization of the crystals of the mucus. Viscosity should be very thin, and there should be no white cells in the cervical mucus on microscopic examination. Also, there should be progressive motile sperm more than 5 to 10 per high power field, and on gross sperm morphology should be within normal. Regarding endometriosis, it is associated with doubling the relative risk of infertility. It is diagnosed and even treated by laparoscopy. It can be familial and can occur in adolescents. Etiology is unknown, but it likely multiple one, like retrograde menstruation, immunologic factor, or genetic factors. Medical option remains suboptimal. Regarding male factors, we test for serum testosterone, FSH, and prolactin level. We do semen analysis, and we do scrotal ultrasound. In some cases, we do testicular biopsy and even sperm penetration assay. In semen analysis, usually we collected after 48 hours of abstinence. It should be evaluated within 1 hour of ejaculation, and if abnormal parameters, it should be repeated in 2 weeks time. Normal semen analysis include volume more than 1.5 ml. Sperm concentration should be more than 15 million. Total sperm number more than 39 million. And per ejaculate, and morphology more than 4% should be normal, and vitality more than 58% live. Progressive motility in more than 32%, and total progressive and non-progressive motility 40%. This is according to WHO. What are the treatment options? Usually, ovarian disorders can be divided to these categories. So we can say for anovulation, we use clomiphene citrate and human chorionic gonadotropin, or human menopausal gonadotropin, or induction plus intrauterine insemination. And if high prolactin, we use Dostinex, bromocriptine, or sometimes in macroadenoma present. If macroadenoma present, we use transsphenoidal surgery. For premature ovarian failure, we don't have too much to do, but high dose of human menopausal gonadotropin can be tried. Central amenorrhea, usually we use at the beginning clomiphene citrate, then human menopausal gonadotropin, and at the end we can use also pulsatile gonadotropin releasing hormone. Luteal phase defect, we use usually progesterone support or dydrogesterone, or we can use clomiphene citrate with HCG. Ovulation induction with clomiphene citrate, usually we induce ovulation in 70% of the cases, but the pregnancy rate is only 40%, compared to 60 to 80% in human menopausal gonadotropin. Usually we start on cycle day 3 or 5, and multifetal rate is 5 to 10%, while it is 10 to 15%, even little higher in HMG group. What are the risks of this clomiphene citrate compared to human menopausal gonadotropin? Usually they are, with clomiphene, they are very simple. Sometimes some vasomotor symptoms or headache, and multiple gestation, while in HMG, multiple gestation is common. Ovarian hyperstimulation is one of the major problems when we stimulate ovulation with human menopausal gonadotropin, and sometimes can be fatal if untreated in intensive care unit. Fallopian tube problems can be managed with tuboplasty, but actually IVF is the best practice in the current days. Uterine corpus for Asherman syndrome, we use hysteroscopic lysis of adhesions or postoperative antibiotics, plus postoperative antibiotics and estradiol. Rarely for fibroid, we need a treatment. Myomectomy, hysteroscopic or laparoscopic or open can be done. Uterine artery embolization is not used for infertility situations because it may affect the ovaries. Uterine anomalies rarely need treatment, and metroplasty is one of the alternatives. If we have cervicitis, we use antibiotics. If scant mucus in the cervix, we use low-dose estrogen, and sperm motility issues, anti-sperm antibodies can be treated by steroids or intrauterine insemination. For endometriosis, excision is better than medical treatment. Laparoscopic lysis of adhesions may help, but invasive and expensive. Gonadotropin releasing hormone analogs, not a cure, and has a side effect and expense. Danazol has side effect and cost. Continuous oral contraceptive pills leading to poor fertility rates. The chances of pregnancy are high within 6 to 1 year after 6 months and 1 to 1 year after treatment. Regarding male factors, hypogonadotrophism usually is treated by human menopausal gonadotropin or gonadotropin releasing hormone, and sometimes treated with clomiphene plus HCG with poor result. Varicocele can be treated with ligation, but no definitive result till now. Some people, they support its use, regular use. Some people, they said wait and do medical management. Retrograde ejaculation is also a problem for male infertility. Can be treated by ephedrine and imipramine. Also, artificial insemination husband can be used with recovered sperm. Idiopathic oligospermia, there is no effective treatment till now. IVF is one of the alternatives. Donor insemination is not an option in Islamic or religious people. Unexplained infertility occur in 5 to 10% of couples. We consider testing for prolactin, doing laparoscopy, other hormonal testing, cultures, anti-sperm antibody testing, sperm penetration assay if not done. We review also previous tests for validity. There are some empirical treatment for unexplained infertility like ovulation induction, antibiotics, IUI, and we consider IVF and its variant if no treatment, no benefit. Adoption is one of the alternatives. In summary, infertility is a common problem. It is a disease of couples. Evaluation must be thorough but individualized. Treatment is available, including IVF, but can be expensive, invasive, and of limited efficacy in some cases. Consultation with a reproductive endocrinologist is advisable. Thank you very much for your listening.
Thank you, Dr. Fawaz, for your excellent presentation and updated information. Dr. Sharif Omar is the Vice President of Leptas Pharmaceuticals. He is joining us from the States. And the topic of Dr. Omar is Afrofem role in female sexual dysfunction, female infertility, and is a couple therapy. Welcome, Dr. Omar. Please share your slides.
So before I start, I'd like to thank you, Dr. Fawaz, for a very thorough and comprehensive presentation on your focus topic. I'll now start sharing my screen. So the topic of our presentation involves many facets of Afrofem. The theme here is to bring back romance. Afrofem restores female sexual desire and stimulates feminine lubrication. It does so through various pharmacological mechanisms, which we will review in detail. And so we want to make this presentation both informative as well as focused on the overall aspects, not just simply the biological aspects. So really, when you look at the differences in gender, and this spans the different cultures in terms of how the male subjects end up dealing with their female partners. So one question is asked, how complicated is a woman's mind? And here's one answer, which says, if you ever want to know what a woman's mind feels like, imagine you're on a computer and you have a browser with over 2,800 tabs open at the same time, all the time. Women are very complex. The way a woman thinks and adapts to her environment and the situation of her life all form a complicated mechanism that drives their overall desire. You can have a simplified version of the male adolescent brain, which essentially is focused on sex. And when you look at the female brain is juggling thoughts about many different aspects: work, family, religion, friendships, shopping, and sex becomes a smaller part of that area of focus. So when we look at the gender perspectives on sex, for women, it is first love. They need to have that emotional bond and connection with their partner in order to be receptive to sexual activity, and then sex, in that order: first love and then sex. For men, it's different. It's first sex and then maybe love. Not necessarily will they fall in love with their partner, but the male focus is the sexual drive, which is a different rate and intensity than that in their female partner. And so how important is sex in life? A study was conducted looking at various aspects of importance in a woman's life, and sex ranked as number 3. First was fidelity, second was respect, third was sex, and surprisingly, children came in 4th, followed by other areas of importance in a woman's life. So why is sex important? Well, there's some very specific reasons of how sex provides a healthier lifestyle. People who have intercourse twice a week or more are less likely to have heart attacks and other fatal coronary events. People who have sex more frequently tend to have a lower diastolic blood pressure. For women, there's a lower risk of breast cancer for those who engage in vaginal intercourse. Not at all or infrequently, they have 3 times the risk of developing breast cancer compared to the counterparts who engage in vaginal intercourse more frequently. For the males, if they ejaculate 21 or more times per month, this reduces the risk of prostate carcinoma by 1/3. So essentially for a man, they should ejaculate every 2 out of every 3 days in order to reduce prostate carcinoma risk. Pain relief. Studies suggest that more sexual activity helps to relieve lower back pain and migraines. And of course, it burns calories. Sex has been found to burn 60 to 85 calories per encounter. For women, sexual activity regulates the hormonal levels as they achieve and they reach menopause and reduces the menopause-related symptoms. Men who engage in frequent intercourse have higher semen volume, sperm count, and percentage of healthier sperm. Now, when we look at female sexual dysfunction, the man is looking at the 101 happy nights, and the woman may be looking at 102 excuses. There are many factors that come into play when looking at female sexual dysfunction. When we look at the etiology, it is a multitude of factors that are psychological, social, relationship-based, organic, and aging. Female sexual dysfunction tends to increase with aging. In fact, there was a study looking at the impact of aging on sexual function and sexual dysfunction in women. In this study, the conclusion is what we already know, that women's sexual function declines with age. The decline, in fact, begins as early as the late 20s to the late 30s, particularly the facets of desire, frequency of orgasm, and sexual intercourse, and they continue to decrease with age. So women can begin this path on sexual dysfunction early in life. If we look at the link between female sexual dysfunction and diabetes, there was a systematic review and meta-analysis which found that female sexual dysfunction is more frequent in the diabetic subjects than the control, and low female sexual function index is also associated with a higher BMI. So if you have patients that are both obese and diabetic, they are at greater risk for developing female sexual dysfunction. If we look at the connection between female sexual dysfunction and oral contraceptives, there was a comparison profile of cycle control, side effects, and sexual satisfaction on 3 hormonal contraceptives. The finding was that disturbance of sexual intercourse due to vaginal dryness and loss of desire is highly associated with use of oral contraceptives. In female sexual dysfunction and infertility, here the incidence and prevalence of female sexual dysfunction was assessed in infertile women. And it found that the domains included orgasm dysfunction, sexual desire, vaginismus, and dyspareunia. So according to the high rate of sexual dysfunction in the study, the gynecologists are recommended to pay more attention to female sexual dysfunction and encourage patients to have a psychiatric evaluation where indicated. The prevalence of female sexual complaints in the National Health and Social Life Survey show that 43% of women ages 18 to 59 had some sexual complaint, about a third had a lack of sexual interest, over a quarter were unable to achieve orgasm, and over 1 in 5 experienced pain during sex. Furthermore, patients fail to talk about sexual problems with physicians because they think their physicians are too busy, the topic is too embarrassing, or there is no treatment available. And so we should encourage physicians to initiate the discussion about female sexual dysfunction to uncover the problem and provide treatment. Female sexual dysfunction is a hidden problem. As we know, in many societies, women are reluctant to discuss it openly. Majority of the cases are silent. And about 2/3 of women do not bring up this topic because of fear of embarrassment. And almost 3/4 don't discuss it because they believe the provider will dismiss their concerns. And so in our community, there's an analysis of an approach to the problem. Within the Arab communities, they're known for their conservative attitude relative to sexual activities. The discussion of sexual issues continues to remain taboo to this day. Sex education on a formal level remains nearly non-existent. But the globalization and internet has led to changing practices, particularly among the youth who are now entering the age category where sexual dysfunction can begin to take hold. And so awareness of available methods for treatment of sexual dysfunction in women is limited. Availability of treatment remains challenging due to a lack of training. Female awareness of their sexual rights is not prevalent, but women and girls have a right to control their bodies and their sexuality without any form of discrimination or violence. So when we look at assessing sexual function in women that have suffered female genital mutilation, in this study, it involved over 130 sexually active women with female genital mutilation and 130 sexually active women without female genital mutilation in Jeddah. And of course, the finding is, as we expect, sexual function in the women that have undergone female genital mutilation is adversely altered. And this adds to the well-known health consequences of FGM or cutting. Female genital mutilation is defined by the World Health Organization as any procedure that involves either partial or total removal of the female external genitalia or injury to the female genital organs for any cultural or other non-therapeutic purpose. Female genital mutilation is still widely practiced in some areas, and the estimate is that 2 million girls are thought to be at risk. In fact, between 100 to 140 million girls and women worldwide are living with the consequences of female genital mutilation. In fact, in Africa alone, it is estimated that about 92 million girls aged 10 years and older have undergone this procedure. Of course, there are immediate and life-threatening as well as long-term complications that are well documented with female genital mutilation or cutting. This can involve shock, infection, clitoral cysts, dysmenorrhea, infertility, recurrent urinary tract infections, obstetric complications, and of course, the psychological and sexual dysfunction problems. Some of these consequences are well documented by strong scientific evidence and by common sense and authoritative opinions. And so sexuality among these patients is not well known and is often neglected by gynecologists, urologists, and sexologists. In the mutilated and cut women, some fundamental structures for the external orgasm have been excised. And so these women still have the possibility to achieve orgasm when we look at the deep orgasm, and these patients with sexual dysfunction can and must be treated. When we look at the etiology of female sexual dysfunction overall, it can be driven by relationship problems, emotional problems, anxiety or depression, insufficient stimulation, gynecologic problems, vaginal dryness, which is the most common cause in younger women, is insufficient stimulation. Women need a significant amount of foreplay, much more so than their male partners. Pain during intercourse, of course, like other sexual problems, this can cause women to lose interest in sex. Medications can reduce desire or arousal. Antidepressants, antihypertensives, antihistamines. Partner sexual dysfunction is a key factor. Of course, if the woman's partner suffers from sexual dysfunction, such as ED or lack of desire, that can then carry over into impact on her sexual dysfunction and function as well. Drugs, there's a whole list of drugs: vascular, endocrine, systemic illness, renal, hepatic, pulmonary, cardiac disease, infections and injury, neurologic, can be spinal cord neuropathy and cortical lesions, as well as psychogenic. They can be psychiatric, intrapsychiatric, particularly if it relates to religious issues, social or family taboos, sexual experiences of low self-esteem, and extrapsychic, particularly with a dysfunctional relationship with their partner. The list of drugs is quite lengthy. It includes psychotropic drugs, histamines, antihistamines, narcotics, NSAIDs, all contraceptives, and a variety of hormones and diuretics, as well as non-selective beta antagonists. The drug-induced female sexual dysfunction can be broken up into 4 categories: those that are psychoactive, cardiovascular, hormonal, and others. Of course, there's an impact driven by comorbidity. Surveys indicate that there's a high concordance of female sexual dysfunction and marital discord and symptoms of anxiety and depression. Studies of sexual function in psychiatric patients suggest that sexual disorders are more common in patients with depression, schizophrenia, anorexia, and anxiety disorders. On the other hand, sexual activity and libido are reported to increase in manic episodes in those bipolar patients. So when we look at libido and female sexual dysfunction, a lack of sexual desire or the lack of the interest or the organic hunger for sexual activity is a common problem in up to 2/3 of women. Lack of desire stops the sexual response cycle before it starts. In some women, it is temporary. In others, it is an ongoing and chronic problem. So in most women who are not experiencing sexual problems, libido and arousal are closely related and difficult to separate. Libido can alternately be referred to as the baseline interest in sexual activity and might be redefined as sexual appetite. Arousal refers to the physiological response to sexual stimulation, increased vaginal swelling and lubrication from blood flow. So the woman must have the desire such that when she's exposed to stimulation, whatever mechanism that comes to, she reacts to it by an aroused state where the blood flow to the vaginal tissue increases. This causes swelling and lubrication. So women with stronger libido generally experience a greater response to sexual stimuli and greater arousal. So libido is the combination of two key elements. There is a hormonal component and a neurological component. Sufficient libido is a result of sufficient levels of androgen binding to sufficient numbers of active sex hormone neuroreceptors. So sufficient sexual interest for normal arousal, orgasm, and resolution is critical. So when we look at the management of female sexual dysfunction, first, we must assess the contributing factors, whether it's lifestyle, alcohol, medication, smoking, diet, exercise, other lifestyle factors, and the partner's sexual function. We take first the non-pharmacologic approaches, education, psychotherapy, cognitive behavioral therapy, couples therapy, and sex therapy. And then we have the pharmacologic approaches, which includes Afrofen and hormonal therapies if indicated. Treatment with testosterone may lead to serious side effects. Women produce about 5% the amount of testosterone that men do. They do need it to be sexually active, but at a dramatically lower concentration. If a woman is administered testosterone without an indication, in those instances, they'll have lower voice, enlarged clitoris, breast tenderness, they may have skin reactions, fluid retention, acne, and increased body hair. And so a safe and effective treatment specifically designed for female sexual dysfunction is Afrofen. And so Afrofen is an oral therapy for female sexual dysfunction combining two active ingredients. The first is lyophilized fish roe, which is the eggs of fish, which contains a group of phospholipids and omega-3 fatty acids responsible for the aphrodisiac effect. The second ingredient is the standardized extract of the ginkgo biloba leaf, which is standardized to 24% flavonoid glycosides and 6% terpene lactones. This is the standard pharmaceutical grade ginkgo biloba leaf extract. So the combined action of these two ingredients in Afrofen creates a synergistic effect on both libido and sexual desire. Seafood, we all know, has a rich history as an aphrodisiac, and when we look at the biochemical components that drive this effect, it's primarily the phospholipids, because the fish roe is very highly concentrated in omega-3 fatty acids and dozens of vitamins and minerals. The lyophilized fish roe is not caviar because there's no salt as a preservative, and the lyophilized fish roe is freeze-dried in our pharmaceutical processing process to ensure the active ingredient is stable, and then it is finally granulated to create a micronized pharmaceutical-grade active ingredient, which maximizes surface area to optimize absorption. Fish roe is up to 3/4 water. It provides concentrated phospholipid, and the cholesterol is removed during the drying process. The mechanism of action of sexual function is via various mechanisms. Libido is increased because lecithin is a major constituent of the cell membrane, and exposure to lecithin causes changes in neurotransmitter receptor availability of the cell membranes. As we mentioned earlier, in order for libido to be active, you must have two components: sufficient levels of androgens, and then the sex hormone neuroreceptors must be sufficiently upregulated to receive those androgens. And so the lecithin in the fish roe helps to nourish and support the integrity of those cell membranes so those neuroreceptors can be available and upregulated to receive those androgens. The lecithin stimulates dopaminergic D1 receptors in the hypothalamus, and this increases sensitivity of sex hormone neuroreceptors to the free testosterone to induce libido. Furthermore, fish oil was found to improve blood flow response to acetylcholine and increase nitric oxide release. Long-term treatment with omega-3 fatty acids is known to improve endothelial-dependent relaxation of blood vessels in animals and humans. The endothelial relaxation caused by omega-3 fatty acids increases arterial compliance, and the serum EPA and DHA levels are inversely associated with the indicators of endothelial dysfunction. And so as we increase EPA and DHA from the fish roe, we reduce the markers of endothelial dysfunction. And so the fish roe stimulates libido by stimulating dopaminergic D1 receptors in the hypothalamus, increases sensitivity of sex hormone neuroreceptors to free testosterone, but it does not increase testosterone secretion. It simply makes the receptors more sensitive to the already circulating testosterone. Ginkgo biloba, as a separate ingredient, the second ingredient in Afrofem, it alone is the most scientifically studied of all phytotherapies, with over 120 published European clinical studies on ginkgo. We use the standardized pharmacologic grade of 24% flavonoid glycosides and 6% terpene lactones. The ginkgo biloba acts as a free radical scavenger. Free radical formation is to a higher extent under certain pathological conditions such as hypoxia and ischemia, and the flavonoid glycosides help to counteract the superoxide free radical that can destroy tissue at a cellular level. The flavonoids will negate the destructive effect of this molecule. Furthermore, it increases peripheral arterial blood flow. The flavonoid glycosides increase the blood flow not only through the arterial vessels, but also in the small vessels and the arterioles and the capillaries. The terpene lactones antagonize the platelet activating factor and reduce blood viscosity. This improves the rheological properties of the blood in all tissues and organs, including the genitalia. And so when we reduce viscosity and we can drive more perfusion of blood to the vaginal tissue, that will increase the blood flow and increase the lubrication as a result. And so the combined actions of Afrofem, the active ingredients on libido and blood circulation, produce a synergistic effect on female sexual activity. Many patients that would use Afrofem will be entering middle age, most likely 40 years of age and older, and it's likely they may suffer from other comorbidities, which may include metabolic disease, some version of that, and poor circulation. Afrofem is indicated for mild to moderate sexual dysfunction due to aging or age-related problems. It's indicated for psychogenically caused sexual dysfunction, reduced sexual activity due to stress, depression, or similar factors, or stress release chemicals which impact sex hormone neuroreceptors, as well as for patients suffering from sexual dysfunction due to pharmacologically induced sexual dysfunction, particularly drugs used to treat depression, hypertension, can cause decreased libido. The dose is 1 capsule 2 to 3 times daily after meals. Most female subjects will achieve an effect from 2 to 6 weeks after treatment begins. Once they achieve their optimal level of effect, they can reduce the dose to 1 capsule daily. And the word optimal is quite subjective. It will vary from patient to patient. It's once your patient is happy with the level of sexual activity they've achieved, at that point, they can reduce their dosage. Afrofem has been administered safely to patients suffering from a variety of diseases: hepatic renal disease, cardiovascular disease, GI diseases, and diabetes as well. Afrofem does not affect the course of illness or most other pharmacologic treatments. If a patient's taking an anticoagulant because it affects blood viscosity, they may just need to adjust that dose. There are no hormone-like adverse effects, does not affect testosterone production. It is safe for long-term use. Afrofem has a very strong safety profile, no hormonal side effects, no cardiovascular effects, no local reactions, no drug-drug or drug-disease interactions. It is safe for long-term use. Of course, Afrofem is made with a combination of fish roe and ginkgo, so obviously if your patient is allergic to those components, they should not be used. Afrofem gradually but steadily improves sexual activity. Some patients may achieve results in as little as 2 to 3 weeks. Most patients will need 4 to 6 weeks of continuous full dose therapy. Rarely, they may need treatment for up to 8 to 12 weeks of full dose. The factors that will impact how quickly your patient reacts and responds is their age. The older the patient is, the longer duration of therapy is required at the outset, and other comorbidities, as well as concomitant therapy with other pharmacologic agents. So why is Afrofem preferred for the treatment of female sexual dysfunction? Because it is the treatment that treats the underlying cause of female sexual dysfunction, deficiency of libido. It treats the root cause of the condition, and it is not simply symptomatic or temporary treatment. Afrofem has a strong safety profile in long-term treatment. We make Afrofem at our FDA-registered a State Board of Pharmacy registered drug manufacturing site in New York, and it is shipped to all markets across the Middle East. So female sexual dysfunction is common and negatively impacts quality of life. Multiple factors may affect sexual function in women across the life cycle. Patients want to discuss their sexual concerns with providers. They're embarrassed to open up the topic, and they're looking for you to take the lead to talk to your patients about their sexual activity. And so the idea is to identify a communication strategy and make a commitment to use it. Structured interview strategies such as Allow or Plicit are effective. AfroFem is specially designed for female sexual dysfunction. We'll shift slightly over to focus on use of AfroFem in patients suffering from infertility. AfroFem, as we mentioned before, reduces the incidence and prevalence of sexual dysfunction in infertile women. In a study of over 500 patients aged 24 to 42, they were assigned to both fertile and infertile groups, and female sexual dysfunction was assessed by the Female Sexual Function Index. Patients with past history of psychiatric illness, diabetes, and hypertension were excluded. Studies show that there's a reduction of incidence and prevalence of sexual dysfunction in infertile women. Female sexual dysfunction has a definite role in infertility, and so appropriate treatment of female sexual dysfunction can preclude the use of expensive and unnecessary fertility treatments. When we look at the impact of AfroFem in cervical mucus, of course, cervical mucus is fluid or gel-like discharge from the cervix that is essential for fertility. After ovulation, the cervical mucus is no longer as wet or slippery. And so the creamy cervical mucus is considered non-fertile because it makes it difficult for sperm to reach the egg. Clomiphene, which is widely used as a fertility drug, helps many couples conceive, but it can also cause a barrier with significant problems with its side effects, specifically vaginal dryness, cervical mucus production, and function. And in fact, women on clomiphene are found to have 7 times more likely to have hostile cervical mucus that is more difficult for sperm to penetrate through than women not on this medication. The ginkgo biloba leaf content in AfroFem helps to relieve cervical mucus poor quality and vaginal dryness. It possesses estrogenic effects, which counteracts the anti-estrogenic effects caused by clomiphene. The ginkgo component of AfroFem improves peripheral blood circulation, and AfroFem increases libido, which increases frequency of intercourse, and this increases vaginal lubrication. And so AfroFem is a non-hormonal aphrodisiac, which contains lyophilized fish oil, rich in omega-3 fatty acids, and the ginkgo biloba leaf extract. AfroFem relieves vaginal dryness caused by clomiphene. Vaginal dryness causes pain to both partners and decreases frequency of sexual intercourse. And AfroFem relieves the stress due to the necessary regular sexual intercourse during the ovulation period by helps to restore female libido and increasing her sexual desire. AfroFem increases frequency of sexual intercourse during the ovulation period by restoring the female libido and increasing sexual desire. And due to vaginal dryness caused by clomiphene, when women have to use lubricants, they can cause harm to the sperm. And so AfroFem naturally increases the natural vaginal secretions and lubrication. AfroFem decreases consumption of the commercial lubricants that can harm the sperm. And so when AfroFem is used in combination with clomiphene, you can help overcome the vaginal dryness caused by the clomiphene to obtain the best results for successful fertilization and conception. AfroFem is the first choice for your patients to treat female sexual desire and stimulate feminine lubrication. We have our combining product, Gentiplex, which is used for male sexual dysfunction. This helps to treat male subfertility. The omega-3 content in semen is among the highest concentration located in the sperm tails. And so if you have male patients with insufficient DHA in their diet, they may suffer from subfertility. Sperm is single cellular and extremely sensitive to free radical attack. And the lyophilized fish oil that's in Gentiplex is rich in omega-3 fatty acids. And so Gentiplex for men can increase sperm count, sperm motility, percent of sperm that is viable. And the ginkgo component, also in the Gentiplex, helps to neutralize superoxide free radicals and protect the single cellular sperm from free radical attack. And so the antioxidant effect in the ginkgo component of Gentaplex helps improve sperm count, motility, spermatogenesis, and sperm viability. For subfertile males, the dose of Gentaplex is 1 capsule 3 times daily until conception. And so for couples therapy, you have the option of using Afrofem for female sexual dysfunction and to stimulate feminine lubrication. And for males that may be subfertile, Gentaplex can help improve the quality of their sperm. And so couple therapy, an essential entity. To optimize therapy, urologists should consider the couple when patient presents with a sexual problem. Otherwise, the risk of inappropriate unsuccessful treatment is high. And so the couple should be seen as a clinical entity, whether they're being treated by a urologist or a gynecologist, obstetrician. So we look at the results of couples therapy. Afrofem has a synergistic effect on female libido and vaginal orgasm. 1 capsule 2 to 3 times a day after meals for 4 to 6 weeks can help bring the romance back to your patients' lives. Thank you.
Thank you, Dr. Omar, for your excellent presentation and updated information. Professor Dr. Azhar Musa, Professor of OB/GYN at Kufa University Medical College. She is a supervisor in Nagaf Center for Arabic Board in OB/GYN, and also she is member of Ishare and Ashram group. And her topic today is special infertility management. Welcome, Professor Dr. Azhar. Please share your slides.
Good afternoon. Thank you, Dr. Ahmed and Dr. Sharif. Thank you for all attendants from outside Iraq and from inside Iraq. Thanks to Liptis. I hope you all will be well and safe from the pandemic of COVID-19. Actually, it is for my honor to be part in this webinar. Though it is very embarrassing to me to have a lecture after 2 exciting, compassionate speakers like Dr. Omar and Dr. Fawaz. I'm going to speak about the special infertility management, which is the third-party management in infertile couple who underwent ICSI. Firstly, I have to apologize about the slides because I prepared it myself and in a short period of 4 days, and I cannot get the help of IT because of lockdown, because of COVID-19 in my governorate. The second thing is all what I'm going to speak about is just speaking. It's not allowed in my country, nor from a religious point of view, neither from social, cultural, and governmental law. But we have to speak about them because it is part of the management of infertility. And I know in all Arab countries of the Gulf, they are not allowing these things. 25th of July, 1978, which is the born of Louis Brown, which is the first successful test tube baby. Making things change. The things before 1978, something in the management, and sure, after 1978, the management of infertility is changed. What we mean by the third-party reproduction, we speak about oocyte donation, sperm donation, embryo donation, surrogacy, uterus transplant, and ovarian transplantation. What about oocyte donation? Whom were indicated for oocyte or ovum donation? First, patients with advanced maternal age, that is to say, they're attaining menopause with a very poor ovarian reserve. The second is a patient with hypergonadotrophic hypogonadism, either because of gonadal agenesis or dysgenesis or something like that. Third, for patients with resistant ovarian syndrome, in spite of using a lot of stimulation protocol, still the ovary is not responding to these protocols. Fourth, patient with ovarian failure, either because of malignancy, surgical castration, radiotherapy, chemotherapy, and so on. Patient with a premature ovarian failure. Then poor oocyte or embryo quality, in which we are trying our best to induce patient, but still what we gain is a very poor oocyte or embryo quality for that particular couple. 7 is the recurrent IVF failure. When we speak about recurrent IVF failure, which is treated by oocyte donation, this is failure of induction, because failure of implantation is something else. It is usually treated by platelet-rich plasma, maybe granulocyte insufflation, maybe because of something. Or 8, patient who have recurrent pregnancy loss. And lastly, patient with genetic disorder, whether she's affected or she's a carrier of the genetic disorder. Now, for the oocyte donation process, we have something about the donor, other about the recipient. For the donor, we have to think, who's going to be the donor? Is it relative, close relative, something else, another woman who are ready to donate, and so on. Then we have to speak about donor screening, and I'm going to give you short notes about how to screen those patients who want to donate their ovary. Then donor matching. We have to think of the skin color, eye color, hair color, and so on. For the recipient couple, we have to take a medical screening, the Mock cycle, because occasionally the patient having contraindication for pregnancy. We have to think for the psychological issue, which is very important. And for the legal issue, and I have told you it is not allowed in my country, then we have to have an ethical concern about these things. What we have to screen for the donor or the donor screening, including we have to take proper medical, personal, family history, if there is any genetic problem in the family. So we are omit this donor and we have to choose another donor in which there is no genetic problem in the family. And we have to ask about the reproductive history of that particular patient. Then we do investigation in form of CPC, urea, creatinine, liver function, renal function, and so on. We have to know about the blood type, because I mean the RH of the donor. We have to do hepatitis screen, VDRL, human immune deficiency virus screen, cervical culture for gonorrhea and chlamydia, then pap smear for the donor, transvaginal ultrasound of the pelvis, and appropriate genetic study it is available. The main principle for ovum donation is preparation of the recipient endometrium. We have to think of window of embryo transfer, or what is called window of implantation. Then we have to think about early pregnancy management with exogenous hormone. Usually preparation of the recipient endometrium, it is either a frozen cycle or it is a segmented cycle. For the frozen, for both of them, we have to prepare the endometrium for receptivity of the fertilized donated sperm, ova, sorry. Usually we prepare the endometrium with the help of estradiol valuroate, which is the estoform, and the progesterone. Usually we prefer oral rather than transdermal patch, and we have to think of window of implantation. Usually the window of implantation measured once we add progesterone within 3 to 5 days from adding of progesterone after estrogen priming of the endometrium. How to prepare the donor. Donor preparation, we have to synchronize the cycle with the recipient and start with the stimulation protocol. We are using either antagonist protocol or long protocol so that to gain more mature oocyte with less incidence of ovarian hyperstimulation syndrome. Preparation of the recipient, I have speak about it. It's just with estrogen, then to add progesterone. But we have to think whether we are going to transfer within this cycle, what is called the fresh cycle of fresh embryo transfer, or we may do freezing, then thawing and embryo transfer, which is the segmented cycle. However, rapidly speaking, algorithm of oocyte donation, we have to have recipient evaluation, then donor secretion. If both is good, we have to obtain informed consent from recipient and donor, then synchronization of the donor and recipient cycle, prescribing of hormone for the recipient so that to prepare the endometrium, ovarian stimulation of the donor with the help of HMG or recombinant gonadotropin, oocyte retrieval from the donor, then fertilization of the oocyte by the husband sperm, by the recipient husband sperm in the lab. Then we have to do the embryo transfer and maintenance of pregnancy in the recipient. The result of donated oocyte or donor oocyte program, pregnancy rate of donor oocyte program actually it is equal or even possibly higher than the routine IVF program. Transfer of fresh embryo has a higher pregnancy rate than that of frozen thawed embryo. Then the age of the donor is very important factor. But the age of the recipient, it has no any significance since any decrease in endometrial lining can be achieved with hormone replacement therapy in form of estrogen and progesterone. About the complication, we have to think of ethical, legal, religious, and social problem. Actually, we have to think of the offspring of that one who's donated hair over and of the offspring of the same mother who is donating hair over. The second line of management in third-party management is the sperm donation. Actually, there is an increasing incidence of non-obstructive azoospermia. However, the only chance these couples have to have a baby is through sperm donation. For the sperm donation, the donor will undergo semen analysis and the sample will be thawed to evaluate post-freezing thawing semen parameter. This is very important because we may do just seminal fluid analysis is okay, but if we are doing the post-freezing thawing semen, it have a different parameters. So we have, because there is a sperm susceptibility to damage with the freezing, varies between individual. So we have to be sure that the donor having very good parameters of semen analysis, go with WHO analysis, which has been attempted by my colleague, Dr. Fawaz, to be fertilized, to be used in fertilization of them. In addition to the medical information that is obtained from the donor, we have to ask the donor about his personal habits, education, and so on. Now, the donor sperm, it may be from relative and it may be from sperm bank. If this is from sperm bank, we have actually a lot of sperm bank they provide with the donor video about his picture and so on, so that the one who want to be the recipient, you have to choose the most nearby picture to him. And the donor may identify themselves as open to contact from any child conceiving through donor insemination once a child reaches legal age. What is the requirement of sperm donor? The individual must be free. So the donor must be free from human immune deficiency virus, hepatitis B and C virus. He should be free from diabetes, hypertension, sexual transmitted disease, identifiable and common genetic disorders, just like thalassemia in the family and so on. We have to be sure that he is free from all of these. Age of the donor must be between 21 and 45. The blood group and RH status of the individual must be determined and placed on record. And if there is any other psychological problem, and we have to know about, this is for the sperm bank, we have to know about height, weight, age, color of skin, psychiatric problem, and any other medical problem or family problem of the donor. This is something about the recent advance in the management. Actually, when I read it, I'm very surprising. They say, as infertility increase and gamete donation decrease, an alternate source of sex cell may provide or may be proven of value. One is the mouse embryonic cell, which can be differentiated into sperm. And the second is the human embryonic cell that can be differentiated into germ cell in culture. Actually, this is just experimental and they work on it now. I didn't know, maybe 1 to 3 years, and they start to use this. The other items of third party is the embryo donation. Actually, embryo donation is a procedure that enables embryos either that were created by a couple undergo infertility treatment or that were created from donor sperm and donor egg, especially for the purpose of donation to be transferred to the infertile patient. That is to say, the infertile patient may gain an embryo either for a couple who have underwent infertility treatment and the excess embryos will be donated to them, or they are choosing a woman and a man who are specially prepared for donation, that is to say, to stimulate this woman to have what is called ovum pickup or retrieval, to fertilize them and then to transfer the embryo to the recipient. The indication for embryo donation include untreatable infertility that involves both partners. Untreatable infertility may be in a single woman, recurrent pregnancy loss thought to be related to embryonic factors. This is the patient have recurrent pregnancy loss and because of embryonic factor. In these cases, they are thinking of embryo donation. And if there is genetic disorder affecting maybe one or both partner. Actually, cryopreservation of excess embryo is widely used. If the couple having IVF, the extra embryo will be cryopreserved and may be used for donation. Success rate of embryo donation depend actually on the quality of the donated embryo, whether he's grade 1, grade 2. This is the success rate actually depending on the quality of the donated embryo. The other points in the special management or third-party management of infertility is the surrogate uterus. Actually, we have some women who have untreatable uterine factors. Either it is congenital, like Rokitansky-Hoswar syndrome, or it is acquired, like TB endometritis. She may be severe Asherman syndrome, which cannot be treated, or she has hysterectomy for, say, cervical neoplasia, or hysterectomy for postpartum hemorrhage, and the patient yet she's not completed her family, and she went further pregnancy. This is the indication for surrogate uterus, and the only chance of those women or those couple who didn't have a uterus or the uterus is present and incapable of function is through surrogacy. IVF surrogacy or full surrogacy is now generally accepted in many countries, but sure not in our country, as a treatment option for infertile women with certain clearly defined medical problem. The first report of a baby being born by gestational surrogacy was from USA in 1985. Actually, in addition to the indication which we are speaking about, that is to say, absence of uterus, remove or the patient hysterectomized or incapable of function because of severe endometritis, TB endometritis, or severe Asherman syndrome. There is now another indication for surrogacy, that is to say, if the patient will have a disease which contraindicate pregnancy, also she may use the help of surrogate uterus in which she implant her embryo, which is from her own ova and her own husband's sperm. Actually, surrogacy has been practiced as a means of helping women who were unable to bear children for a lot of centuries. Of the different form of surrogate, it is commonly practiced to use the term surrogate mother or surrogate host or surrogacy for the woman who carries and delivers the baby. Gestational surrogacy or full surrogacy or IVF surrogacy are defined as treatment by which the gametes of the genetic couple or intended parent or commission couples in a surrogate arrangement are used to produce embryo from their own ova and their own sperm. And these embryos are subsequently transferred to a woman to agree to act as a host for these embryos. The surrogate host is therefore genetically, didn't have any genetic relationship to any of offspring that may be born as a result of this arrangement. Because she's just the host, while the commencing genetic couples, or what is called a biological, they were having the genetic relationship. So in full surrogacy, there is no any genetic relationship or genetically unrelated to the woman who worked as a host. For natural surrogacy or partial surrogacy, they are speaking about when the intended host is inseminated with artificial insemination with the semen of the husband, of the genetic couple. Any resulted child in partial surrogacy is therefore genetically related to the host because she is using her own ova and she had been had artificial insemination with sperm of the male of the couple who want to have the child. The couple who initiate the surrogacy arrangement and whose gametes are used will be known as the genetic couple, and the woman who subsequently carried the child, I have told you, it is the surrogate host. What is the indication for gestational surrogacy? The genetic couples are divided into two categories: those without uterus and those with uterus. For without uterus, it may be congenital or acquired. Congenital, like Rokitansky host or host-wired syndrome, and the acquired, as I have said, maybe post-hysterectomy because of postpartum hemorrhage, severe endometrial, severe Asherman syndrome, which is intractable to treatment, or severe TB endometritis, and so on. The second category, who have indication for gestational surrogacy, is a patient with uterus but unable to conceive, include repeated implantation failure, repeated fetal loss, and various underlying maternal condition where pregnancy is medically contraindicated. The main indication in general may be Rokitansky host-wired syndrome, acquired reason, plus following endometrial hysterectomy following endometrial carcinoma, placental-site tumor, huge fibroid, cesarean hysterectomy because of postpartum hemorrhage. The patient may have repeated miscarriage and no cause can be identified. And so the chance if they are using a surrogate mother will be more to have a living child. Failure of treatment of IVF treatment is also a relative and rare indication for surrogacy, but it has only been used for women who have never shown any sign of implantation normal embryo in an apparently normal uterus after at least 6 to 8 IVF embryo transfer trial. Here, implantation failure, this is repeated implantation failure. This is different from because failure of IVF may be failure of induction. That is, we use drug and we cannot induce ovary. Or maybe we have an embryo, but there is failure of implantation. Here, in a patient with repeated implantation failure, after 6 to 8 embryo transfer trial, if she didn't conceive, there is an indication for surrogacy. That is to say, to implant her embryo in a surrogate mother uterus. Maybe a patient having Asherman syndrome, endometrial carcinoma, or a patient who have very thin endometrium, which is retractable to treatment. We are using platelet-rich plasma, granulocyte, and so on, but still the estrogen, high dose, but still the endometrium doesn't respond. There is no thickening of the endometrium. In these cases, we may go to surrogate uterus. Or is the patient having medical contraindication for pregnancy, like renal failure, having severe antiphospholipid antibody syndrome with systemic involvement, severe heart disease such as maternal cardiopathy, or other underlying disease, just like patient having severe recurrent preeclamptic toxemia in each pregnancy. In those patients, they may go to surrogate uterus. Patient with uveitis, potentially causing blindness during pregnancy. Patient with hormone-dependent congenital hemangioma of the neck, like Budd-Chiari syndrome, and post-removal of adenoma causing Cushing syndrome, and post-lung transplantation. All of this is contraindication for pregnancy. And if the couple wish pregnancy, they have to give the embryo, which is a result of the genetic mother, genetic father, but they have to implant it in a surrogate uterus. The age of surrogate mother should be between 22 and 35 years. She's expected to be unmarried, whether single or divorced, with at least one child, but with a history of no more than 4 past deliveries and no more than 1 cesarean section. If you have 2 cesarean sections, she's eligible or having a higher risk for complication if she works as a surrogate mother. It must be at least 1 year, and it must be at least 1 year since any delivery of her own child. So her last child should be more than 1 year in age. What issues to have discussed for the host include full implication of undergoing treatment by IVF surrogacy, possibility of multiple pregnancy, and possibilities of fetal reduction, possibility of family and friend being against such treatment. We have to think of this. Need to abstain from unprotected sexual intercourse during and just before the treatment. She has to be protected so that not going to be pregnant from her own husband. The normal medical risk associated with the pregnancy, including she may get abortion, ectopic pregnancy, premature delivery, and possibilities of cesarean section delivery. Implication and feeling of guilt on both sides if the host should spontaneously abort. the pregnancy, possibility that the host will feel a sense of bereavement and she give the baby to the genetic couple, and the possibility that the child may be born with handicap. And in these cases, maybe neither the genetic parents nor the surrogate mother will accept him if you have a handicap. Lastly, the uterus transplantation. Uterus transplantation, the indication is just like for a patient who didn't have a uterus, either congenital because of Myra-Kudinski-Hoswart syndrome, or she had been hysterectomized, as we say, for cervical carcinoma or severe postpartum hemorrhage. Those patients is candidate for surrogacy, but if they refuse surrogacy because of religious, social, cultural problem, they may go to uterus transplant. The donor may be a live donor and maybe a dead donor. There is a lot of trial for uterus transplant. The first trial in the world was in Saudi Arabia, actually, but the patient having rejection, and they removed the uterus after 3 months of uterus transplant. And the first successful, as have been written in the literatures, successful live birth after uterus transplant was in 2016 in Brazil. Whether live donor or dead donor, you know, the live donor, we can prepare the recipient well, but in dead donor, we cannot prepare. But the fact that surgery in dead donor is much, much easier than surgery on the live donor. Because the problem with uterus transplant is not for the woman who's going to be transplanted, but for the donor. If it's live donor, there is possibility of damage to the ureter because we have to have a long uterine artery part so that to be transplanted to the recipient for good vascularization. For those patients who may undergo uterus transplant, usually they be kept on immunosuppressive drug. And they have to have their pregnancy 1 year after uterus transplant because of possibilities of rejection. Actually, the rejection is difficult to be in uterus transplant because there is no, we know about, if we are speaking about, let's say, renal transplantation, we can't check serum creatinine and urea and to say whether there is a problem or not. But in those patients, we didn't have marker to be checked. We depend on the clinical presentation of the patient, high fever, vaginal discharge, so on. And if it is possible to depend on the cervical biopsy, that we are taking cervical biopsy every 2 weeks or every 1 week to see whether there is rejection or not. During pregnancy, they have to be kept on the immunosuppressive drug. And they may need to increase the doses because of what is called hydremia of pregnancy. The last fact about those patients with uterus transplant, those patients is not allowed to have, after transplant, they are not a candidate for a normal pregnancies because, you know, functioning of the tubes and it's not in relationship to the ovary. So for the recipient, suppose that the patient having Rokitansky-Hoswart syndrome, we have to induce them, do ovum pickup, fertilize those ova by the husband's sperm, gain the embryo, and vitrify or freeze the embryos. Then the uterine transplant has been done. After 1 year of successful uterine transplant without rejection, the embryo is going to be transferred to the donated uterus. Then about the legality of the child, this legality is documented in the UK. This is the Royal College guideline, which is not accepted. I told you that we didn't have to do these things in our country, not accepted by from religious point of view. They are speaking about what should be done for the child. Is it legal to do this? It is illegal. The child is going to be related to whom? For the mother who's giving birth, for the mother who's giving the ova. And I think have finished time so that I'm not going to go through this legal issue. And thank you.
Thank you very much, Professor Dr. Azhar, for your excellent presentation and updated topics today. Thank you very much.
Thank you, Doctor. Thank you.
So now it is the session of questions and answers. In fact, we have over 450 participants today, and I see a lot of people, they raised their hands, they want to ask questions. So please, if you would like to ask a question, you can post it in writing in the question and answer window, and then the speakers can handle this one. And we would like just to select a few questions. We can say one or two questions per each speaker in order to finalize the sessions, because if we make answers for all questions, it will take too much time. So we can start with Dr. Fawaz. If you have any question or comment from the question and answer window, Dr. Fawaz, and you would like to highlight or to answer it, live answer, so everybody can hear, please go ahead.
Dr. Ahmed, should I answer? There is one question actually regarding hydrosalpinx.
Yes, please, Dr. Fawaz, yes.
So I will answer live. Actually, hydrosalpinx is one of the negative finding when we go for IVF. So the best is to remove it to improve the result. But some people, they try without removal and the results are poor.
Thank you, Dr. Fawaz. Thanks a lot.
Dr. Fawaz, can I have a question for you? Is better to remove, that is to do salpingectomy, or just to do tube?
To remove it.
Because there is a lot of literature, they say if you remove it, you may interfere with the blood supply to the ovary. So a lot of literature is about just a tubal ligation.
Many people, they try to keep it, and I think the results are poor, and the possibility of pregnancy is high.
Proximal tubal ligation. I didn't know, but it would have been written in the literature. Some agree for salpingectomy. Some say that salpingectomy will interfere with the blood supply to the ovary, so that it will ovarian repair. So they think proximal tubal ligation. I didn't know.
Yeah, it's actually there is a difference in opinion, but I agree with you. It may affect any surgery to the area, may affect the blood supply. But you know, the ovary has two sources of supply, one side from the uterus and one from the top, from coming from renal artery.
Yeah.
Thank you very much. So for we can move to Dr. Sharif Omar. Also, Dr. Omar, if you have one question or two questions you would like to highlight or to answer them on live.
I guess the question that I'll focus on here is Afrofem and pregnancy. The question is whether Afrofem is safe for treating the vaginal dryness during pregnancy. As a general rule, we do not recommend use of our products during pregnancy because they have not been studied in pregnant subjects. And so we don't recommend it either during pregnancy or during breastfeeding because it's unknown what impact that may have on the fetus or the breastfeeding child.
Thank you, Dr. Omar. And I guess there is a repeated question for the same also question about Afrofem safety during the treatment of vaginal dryness with pregnancy. So I guess it is the same answer because here there is pregnancy. Yes. Thank you, Dr. Omar. Professor Dr. Azhar, please.
The first question from Dr. Wasan Safi, she's speaking about pap smear in the donor prior to process of preparation. Actually, this is part of routine, just like doing pap smear in the antenatal period. Because if this patient having something wrong with the cervix and she start her symptom during induction, we may have to stop the induction. So we have to be sure that she's free from any problem in the cervix before trying treatment. For the question of Dr. Malak, she's asking about autosomal disorder in, say, in a couple who have, conducting IVF. You know that if the patient is a carrier, either we are doing the PGD, that is to say we have to have embryos, then we do what is called pre-PGT, that is to say preconceptional genetic diagnosis. And if the embryo were carrying the disorder, we are not going to implant it. If he's free from disorder, we may do embryo transfer. This is one. The other option is just the donor ova or donor sperm. So either we have the embryo from the couple themselves, and we do the preconceptional diagnosis, the PGD for effective. We are not using the embryo. If he's not affected, we have to use the embryo and we have to transfer in the uterus, while the other option is ovum or sperm donation. About the success rate, actually, I didn't know about. I didn't have the data about the success rate. Thank you.
Thank you, Dr. Azhar. We can make a round question again. Dr. Fawaz, if you have any new question or comment you would like to highlight.
Actually, there is one also another the same problem without regarding hydrosalpinx. They said if the tube is closed, it will affect the success rate. Yes, it will affect. Even the presence of hydrosalpinx will be negative on the success of IVF.
Thank you. Dr. Omar?
So the other question here is the maximum time for using Afrofem and the maintenance dose after getting good feedback. So there is no maximum duration of therapy. Of course, if your patient uses Afrofem, she's satisfied with the results, dose can be reduced from 3 capsules daily to 1 or 2 for maintenance. If they stop using it, then gradually they'll revert back to the condition they were in. But if they restart, the reaction time will be faster if they reinitiate therapy after discontinuing. It's really subjective to the level of reaction or satisfaction that your patient achieves. There's another question here about gentiplex and sperm morphology. So if the morphology is impacted because the patient is subjected to free radical attack, either through smoking or through exposure to alcohol or other superoxide free radicals that affect the integrity of the sperm cell, it can help. But it's primarily indicated for those with lower sperm count and poor sperm motility. And so for those patients, the gentiplex components will increase the integrity of the sperm cell, and the ginkgo will protect it from superoxide attack. And dose there, of course, is capsule 3 times daily.
Thank you. Professor Dr. Azhar, also there is... yes.
Okay, thank you. For Dr. Nidal, she's speaking about PRP injection into the ovary. Yes, there is a lot of trial, but still the data is not conclusive. And here in these cases, for patients with premature ovarian failure or poor ovarian reserve, we may use platelet-rich plasma to be injected in the ovary, but still the result, they say it is promising, but there is no actual data about these things. The other for Surah Shadr, Dr. Surah Shadr, I think I've answered online this. For the surrogate or complete surrogacy, in these cases, we have a couple. We use the ova of that woman, the sperm of her husband, we gain the embryo, then we transfer the embryo to a surrogate mother or full surrogacy. While the gestational surrogacy, this is another funny thing. What they are doing, they are just, for the surrogate mother, she's using her own ova, that is to say, she have what is called a donor insemination. Instead, this is intrauterine insemination by the sperm of the husband, or by the sperm of the man in the couple. I mean, if we have a couple, and we are using the sperm of the man to have artificial insemination in that woman, and this is the gestational surrogacy, in which the baby is coming to have to have what is called genetic relationship to the mother. I didn't know whether you got what I mean or not.
Thank you, Professor Dr. Azhar. And I guess it is just enough for now, because there is a lot of questions, but it will take too much time. We are almost approaching 2 hours of the webinar.
So We want to offer our sincere appreciation to Dr. Fawaz and Professor Azhar for joining us and accepting our invitation to share their experience and their wisdom. So thank you, both of you, for taking the time out of your busy schedule to join our sessions today. This is a certificate of appreciation for Professor Azhar and a certificate of appreciation for Dr. Fawaz. Thank you, both of you. And to all participants, we thank you for joining our session. We hope you enjoyed it, and we look forward to you joining us in future sessions once they are scheduled. Everyone, we wish you all to stay safe and healthy in these times.
Thank you. Thank you.
Thank you all for your active participation and presentations, and goodbye. We will be waiting until everybody leaves the room, and then we will terminate the screen after that. So thank you very much. Thanks a lot, and goodbye.
Well,